Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important session. So in the previous lecture, we had started off with the adipocytic tumors and we had discussed in details the benign lesions like lipoma and its variants, hibernoma and lipoblastomas. In today's topic of discussion, we are going to continue with the adipocytic tumors, but we are going to see the malignant tumors, okay, malignant adipocytic tumors. Very importantly, we are going to discuss in details about liposarcoma. Now mind it, this is a very important exam question. It is in fact the most commonly asked exam slide. So around 90% of the residents, okay, they will be asked question on liposarcoma. Even they are asked in your vivas. So in today's topic of discussion, we are not only going to discuss in details about the liposarcoma, but we are also going to discuss in accordance with the WHO 5th edition, according to whatever guidelines is given by the WHO. Okay. So let us begin today's topic of discussion without wasting any more time. So liposarcomas, if you see, they are the malignant tumors of adipose tissue and they are the most common sarcomas of adulthood. So liposarcoma, it is the single most common soft tissue sarcoma and accounts for at least 20% of all these sarcomas in adulthood. It has three principal forms: the well differentiated liposarcoma or atypical lipomatous tumor, of which the dedifferentiated type is the variant. So this is the number one variant. Secondly, we are having mixoid variant of mixoid liposarcoma, of which the so-called round cell type is a variant. Then thirdly, we are having the pleomorphic variety of liposarcoma. So the cardinal diagnostic feature was traditionally the presence of lipoblast, okay, but the current WHO 5th edition states that the presence of lipoblast does help in the diagnosis, but it is not essential for making a diagnosis, okay. So that is why the cardinal diagnostic feature was traditionally the presence of lipoblast, but additional alternative criteria exist for the recognition of well differentiated atypical lipomatous lesion. Now, special stains for lipid and IHC, generally they are playing no essential role, except that on occasion S100 protein staining may highlight the multi-vacuolated lipoblast, as well as the tumor cells in round cell liposarcoma are also often S100 positive. So basically the major role of S100 or the IHC is just to highlight the lipoblast or the adipocytic nature of the tumor in conditions where the lipoblast are not readily visible histologically. Furthermore, the staining for MDM2 and CDK4 may be very useful in the diagnosis of atypical lipomatous tumor and dedifferentiated liposarcoma because they are containing such amplification. We will come into the details of that. Right now, we are just discussing the basics of liposarcoma. Although univacuolated lipoblast are quite common, they may easily be confused with small vessels in cross section, and therefore multi-vacuolated lipoblasts, they are the principal diagnostic requirement according to the WHO 5th edition. These cells, they have two or more sharply outlined, often large cytoplasmic vacuoles that is going to indent or scallop an atypical hyperchromatic nucleus. So how does a multi-vacuolated lipoblast look like? Let me show you. If you look over this figure, so what can you appreciate over here? So there are multiple vacuoles, right? That is why they are called as multi-vacuolated, okay, and they are indented, and this nucleus, if you see, they are atypical, they are hyperchromatic, and these vacuoles, they are indenting or scalloping, okay, the nucleus, okay. So this is basically the classical multi-vacuolated lipoblast, and the presence of such lipoblast, they are very important for the diagnosis, okay. So if you are looking at a lipoblast, it is the multi-vacuolated lipoblast which are very important, okay. So this is the typical lipoblast from a case of a metastatic liposarcoma showing nuclear indentation. See, this particular vacuole is indenting the nucleus like this. That is why we are saying nuclear indentation by lipid containing cytoplasmic vacuoles, okay. So this is how a multi-vacuolated lipoblast looks like. Multinucleation is also very common. Now the process that truly mimics these multi-vacuolated, okay, cells is a silicon granuloma, most often encountered adjacent to a breast implant. The distinction from liposarcoma usually is easy, as well differentiated lesions never have such numerous lipoblasts. So what are some of the benign conditions wherein you will see a lot of lipoblast? So one condition is a silicon granuloma wherein you are putting a breast implant. So near that you can see some some reaction to that particular foreign body, that is for the silicon granuloma. So how do you recognize the presence and how do you differentiate? See, the number of lipoblasts that you can appreciate over here is far more as compared to what do you see in a well differentiated liposarcoma. Secondly, you can see the presence of foreign body type of giant cells in the case of silicon granuloma. So this is one of the very important differential diagnosis of multivacuolated lipoblasts. So liposarcoma is a tumor of adulthood and shows a slight male preponderance. Overall, the peak age at onset is 5th to 7th decade of life. So liposarcoma in children is extremely rare and mostly confined to 10 to 15-year age group. It is most often myxoid in type and usually carries an excellent prognosis. In adults, the clinical features vary somewhat according to the histological type. But in general, the very large majority of the cases, they are deep-seated and the rate of growth parallels the histological grade. Myxoid tumors mainly affect somewhat younger adults in the 3rd to 5th decades than do other types. A history of large, long-standing mass showing recent rapid growth usually indicates either de-differentiation or else progression of a myxoid lesion to its high-grade form, that is the round cell form. Okay. So 35% of the liposarcomas, they arise in the lower limb, especially in the thighs, 22% on the trunk or around limb girdles, 15% in the upper limb, 15% in the retroperitoneum, 8% in the head, neck or mediastinum, and 5% in the spermatic cord. Although liposarcomas of the posterior neck, upper back and shoulder certainly occur, it should be remembered that this is the classical site for benign adipose tissue tumors like lipoma, which can simulate liposarcoma, including spindle cell lipoma or pleomorphic lipoma, lipoblastoma, as well as hibernoma. So whenever you are coming across an adipocytic tumor which is showing atypicality, but they are present in locations like the posterior neck, upper back or shoulder. Okay, so you should always think of certain benign entities like spindle cell lipoma or pleomorphic lipoma, lipoblastoma or lipoblastomatosis and hibernoma. Grossly, the liposarcomas are well circumscribed but not encapsulated. Depending on the subtype, they may have a mucoid cut surface suggestive of myxoma and a bright yellow appearance mimicking lipoma. So, although not necessarily required for the diagnosis of some subtypes, the common morphological denominator of liposarcoma is the presence of lipoblast. So, this appears as a mononuclear or multinucleated cell with one or more cytoplasmic vacuoles that contain lipid. The nucleus is often pushed aside by a single large vacuole, resulting in a signet ring configuration, or it may remain centrally located but exhibit small sharp indentations by multiple small lipid vacuoles. So we have already seen how a lipoblast can be. It can either be univacuolated or multivacuolated, and multivacuolated lipoblast, they carry more diagnostic importance as compared to the univacuolated lipoblast. When the site is related to the histological type, myxoid, round cell and pleomorphic liposarcomas, they show an overwhelming predilection for the limbs. Well differentiated lesions are equally divided between the limbs and the retroperitoneum, and de-differentiated lesions are by far the most common in the retroperitoneum. A tendency for multicentricity in liposarcoma has been described, but this reflects indolent soft tissue metastasis, a characteristic feature of the myxoid subtype, and disseminated disease eventually develops in most such patients. Now, approximate survival figures at 5 years for well differentiated lesion is 90%, and at 10 years it becomes 60%. Okay, for de-differentiated lesions it is 60 to 70%, and at 10 years is 40 to 50%. For pure myxoid lesion it is 90%. For myxoid and round cell hypercellular lesion it is 40 to 50%. For pure round cell high grade myxoid lesion it is 25%, and for pleomorphic lesions around 50 to 60%. So now first we are going to start with the well differentiated liposarcoma or atypical lipomatous tumor. So again, a very important exam slide. Okay, so atypical. So first we are going to see the definition which has been given in accordance with the WHO 5th edition. So atypical lipomatous tumor or well differentiated liposarcoma, we call it as ALT or WDLPS. It is a locally aggressive mesenchymal neoplasm composed either entirely or partly of an adipocytic proliferation showing at least focal nuclear atypia in both the adipocytes as well as the stromal cell. So atypia is not only confined to the adipocyte, but atypia is also seen in the stromal cells. Now, atypical lipomatous tumor and well-differentiated liposarcomas, they are synonyms describing lesions that are morphologically and genetically identical. But why we are using these two terms, we are going to see, okay, right now, because the examiner is going to ask you, okay, if both of them are same, then why you are using both the terms? So, there is a significance of usage of both these terms, I will tell you. Amplification of MDM2 and or CDK4 is almost always present. So, this is the diagnostic, genetic or molecular alteration that is there in case of well-differentiated liposarcoma or atypical lipomatous tumor. So, what are the subtypes of well-differentiated liposarcoma? So, you have three important subtypes: lipoma-like, inflammatory liposarcoma, and sclerosing variety of liposarcoma. So, ALT most frequently occurs in the deep soft tissues of proximal extremities, the thighs and the buttocks, and the trunk, back and the shoulders. The retroperitoneum and the paratesticular area are also commonly involved. ALT usually presents as a deep-seated painless mass that can slowly attain a very large size, particularly in the peritoneum. Retroperitoneal lesions are often asymptomatic until the tumor exceeds 20 centimeters in diameter. ALT WDLPS represents the largest group of adipocytic malignancies, accounting for approximately 40 to 45% of all liposarcomas. These lesions occur predominantly in middle-aged adults with peak incidence between 4th and 5th decades of life. Convincing examples in childhood are extremely rare but may be associated with Li-Fraumeni syndrome. Males and females are equally affected, with the obvious exception of those lesions affecting the spermatic cord. ALT WDLPS may be associated with Li-Fraumeni syndrome, but nearly all cases are sporadic in nature. Okay. Nearly all cases are sporadic and the etiology of these is unknown. ALT is characterized by supernumerary ring and giant marker chromosome. So, they have the presence of this ring and giant marker chromosome, which is harboring the amplifications in this particular chromosomal region 12q13 to q15, which includes p53 inhibitor MDM2. So, there is amplification of MDM2, and in addition to MDM2, many other genes are amplified as well. So, grossly if you see, the ALT is usually large, well circumscribed, lobulated. So, you can see that they have multiple lobules. So, they are lobulated mass. Variable consistencies are present from firm gray to gelatinous areas depending on the proportion of fibrous and myxoid component. Large retroperitoneal tumors appear more heterogeneous, often containing foci of fat necrosis and punctate hemorrhage. Coming to the microscopy, so ALT WDLPS, they can be subdivided morphologically into three types. One is the lipoma-like subtype, sclerosing variety, and inflammatory variety. The presence of more than one morphological pattern in the same lesion is very common and particularly seen in retroperitoneal tumors. So, let us see the histology of each one of them. So, the lipoma-like variety, lipoma-like ALT or WDLPS, it is composed of mature adipocytes in which, unlike in benign lipoma, substantial variation in the cell size is appreciated alongside nuclear atypia in the fat cells or stromal spindle cell. Now, very important, see, along with this, they are having mature adipocytes and there is a lot of variation in the size. This is how you differentiate the atypical lipomatous tumor from the benign lipoma. In the benign lipoma, there will not be that much variation in cell size shape, but over here there is lots of variation. The other important differential diagnosis from lipoma is that there is a nuclear atypia in the fat cells in case of liposarcoma, as well as the atypia is there in the stromal spindle cells. So, this point is very important. Scattered hyperchromatic stromal spindle cells are easily identified within the fibrous septa or the blood vessel wall, and this is a very important requirement for diagnosis of liposarcoma. Occasionally, the fat cells assume hibernoma-like features. A varying number of lipoblasts, okay, from many to none can be found. Importantly, the mere presence of lipoblasts neither makes nor is required for diagnosis. Why? The reason we have discussed in the previous lecture. Firstly, lipoblasts, if you see, they are seen in many benign lesions as well, or benign tumors of liposarcoma as well, benign lesions of the adipocytes as well. Okay, so that is why lipoblast, they are not necessary for diagnosis. Then sclerosing ALT or WDLPS, it ranks second in frequency. This pattern is most often seen in the retroperitoneum or spermatic cord. The main histological finding is the presence of scattered bizarre stromal cells exhibiting marked nuclear hyperchromasia and set in an extensive fibrillary collagenous stroma. Multi-vacuolated lipoblast can be observed. The fibrous component may overshadow lipogenic areas, which can therefore be easily missed in a small sample. Now, the third variety is the inflammatory variety, which represents the rarest subtype occurring most often in the retroperitoneum. A chronic inflammatory infiltrate predominates to the extent that the adipocytic nature of the neoplasm can become obscured. So, let me show you with the help of the diagram. So, what you see over here on the left hand side, this is the classical, the lipoma-like variety. You can see that there are different sizes of mature adipocytes, or the adipocyte, they are of different sizes. Okay, but what is very striking over here, we cannot see any lipoblasts, but what is very striking is the atypical hyperchromatic nucleus which is present in the stroma. This is the stroma, right? So the presence of atypical hyperchromatic stromal cell is an essential diagnostic feature. I want to lay more stress on this point. Now a variable, now you can also see lipoblast. As you can see, this is one lipoblast, another lipoblast, this lipoblast is also. These are all multivacuolated lipoblast. Along with that, you can see the hyperchromatic atypical nucleus present in the stroma. So a variable number of lipoblast can be seen in the atypical lipomatous well-differentiated liposarcoma. However, their presence neither makes nor is required for diagnosis of liposarcoma. Again, I'm telling this point. When dealing with cases in which the adipocytic component is very scarce, so the presence of bizarre multinucleated stromal cells represents a useful diagnostic clue. Now, a rare finding in the well-differentiated liposarcoma or an atypical lipomatous tumor is the presence of mature heterologous differentiation, which can be osseous or myogenic but does not itself imply de-differentiation. Remember this point. It is also important also to note that these atypical fatty neoplasm, irrespective of the location and whether or not they contain lipoblast, they are characterized karyotypically by the presence of ring or giant marker chromosomes derived from the long arm of chromosome number 12. Now, these ring or marker chromosomes contain innumerable copies or amplifications of MDM2, CDK4 and HMG-A2 genes. The resulting overexpression of MDM2 and CDK4 protein has proved to be a useful IHC marker for both well-differentiated and de-differentiated liposarcoma. MDM2 and or CDK4 nuclear immunopositivity is present in most cases. Detection of MDM2 and or CDK4 amplification serves to distinguish ALT from benign adipose tumors. In lipoma like ALT or well-differentiated liposarcoma, MDM2 and CDK4 expression may prove difficult to evaluate, making FISH a valid alternative. A major pitfall is represented by MDM2 nuclear positivity in the histiocytes in the fat necrosis. ALT, WDLPS associated with Leigh-Fraumeni syndrome, they are MDM2 negative, however, they express P53. So the prognosis and predictions. So well-differentiated liposarcoma, they show no potential for metastasis unless it undergoes de-differentiation, therefore justifying the introduction of the term atypical lipomatous tumor for lesions arising at anatomical sites for which complete surgical resection is curative. For lesions arising in anatomical sites such as the retroperitoneum, spermatic cord and mediastinum, which have shown greater potential for disease progression, retention of the term well-differentiated liposarcoma can be readily justified. So try to understand what we are saying. For lesions which are arising in anatomical sites such as the retroperitoneum, spermatic cord and mediastinum, which have shown greater potential for disease progression, so for such lesions, you should use the term well-differentiated liposarcoma. So the most important prognostic factor is the anatomical location. Lesions located in surgically amenable anatomical location, they do not recur after complete excision. Tumors occurring in deep anatomical sites such as the retroperitoneum, spermatic cord or mediastinum, they tend to recur repeatedly and eventually cause death as a result of uncontrolled local effects or less often as a result of systemic spread subsequent to de-differentiation. And that is why such lesions, they are termed as well-differentiated liposarcoma, whereas lesions which are superficial, readily amenable to surgical excision, they are called as atypical lipomatous tumor. In the retroperitoneum, multivisceral resections may increase relapse-free survival. The ultimate risk of de-differentiation varies according to the site and lesional duration and probably is more than 20% in retroperitoneum and less than equal to 2% in the limbs. The overall 10-year to 20-year mortality rates range from essentially 0% for ALT of the extremities to more than 80% for well-differentiated liposarcomas occurring in the retroperitoneum. The median time to death is between 6 to 11 years. So it is preferred to use the term well-differentiated liposarcoma only for lesions which are present in the retroperitoneum, spermatic cord and mediastinum that may kill through their local effects or those of local recurrence, and to designate all those lesions in surgically amenable locations, that is principally the limbs and the trunk, as atypical lipomatous tumor with an explanatory note in the pathology report concerning the biology. This avoids significant social and psychological consequences of an unnecessary diagnosis of sarcoma. So the differential diagnosis of well-differentiated liposarcoma, number 1 is the panniculitis. So mature adipose tissue showing fat necrosis, acute inflammation and lipid-laden macrophages might be mistaken for liposarcoma. Spindle cell or pleomorphic lipoma. Now remember, the spindle cell the pleomorphic lipoma typically seen on the upper trunk superficially. They are comprised of uniform spindle cells admixed with mature adipose tissue. The pleomorphic pattern is characterized by hyperchromatic multinucleated floret-like giant cells. Both often contains ropey collagen. And remember, CD34 positivity is present in both these types of lipomas and they lack MDM2 amplification. This is how you will differentiate the spindle cell or pleomorphic lipoma from liposarcoma. Then angiolipoma, typically seen in the kidney but may occur in the soft tissues, composed of mature fat, smooth muscle and thick walled vessels. They are positive for HMB45, MART1 or PNL2. Now the benign lesions most commonly confused with ALT, they are lipoblastoma, spindle cell pleomorphic lipoma, myxoid inflamed necrotic lipoma, lipogranuloma, localized lipoatrophy, subconjunctival herniated orbital fat and massive localized lymphedema. Okay, so these are some of the differential diagnoses of well-differentiated liposarcoma. To summarize, the nomenclature for well-differentiated liposarcoma and atypical lipomatous tumor is not always consistent, but WDL is often used for deep masses, whereas ALT is reserved for superficial lesions amenable to complete surgical resection. The identification of lipoblast is neither necessary nor sufficient for diagnosis of liposarcoma. Lipoma-like sclerosing and inflammatory patterns often coexist in liposarcomas of retroperitoneum. WDL and ALT rarely metastasize but show frequent recurrence and have the potential to de-differentiate. Surgical excision with wide margin of resection is the treatment of choice. Now comes the de-differentiated liposarcoma, which is regarded as a variant of well-differentiated or atypical lipomatous tumor. Now, de-differentiated liposarcoma is an atypical lipomatous tumor or well-differentiated liposarcoma showing progression either in primary or in a recurrence to usually non-lipogenic sarcoma of variable histological grade. Okay, so over here what happens that basically an atypical lipomatous tumor or a well-differentiated liposarcoma, they are progressing to either a primary or in case of means there was one lesion that has only progressed to a non-lipogenic sarcoma, or the primary tumor was removed and when the recurrence happened, inside of the recurrence there was progression to a non-lipogenic sarcoma. In most cases, there is amplification of MDM2 and CDK4, thus suggesting that they are genetically related to well-differentiated or atypical lipomatous tumor. A well-differentiated component may not be identifiable in de-differentiated liposarcoma.